Hello, everyone. Good morning, afternoon, and evening to you all. Welcome to part 8 of our Exploring Ethics webinar series. Thank you all very much for joining us. We appreciate you being here during a different time slot than the rest of our series for our incredible speaker who's joining us all the way from Australia. Today's presentation is the second last in our series. As a reminder, our series takes place every Wednesday on the same Zoom link, so we look forward to seeing you one last time next week on Wednesday, June 1st. Please take a look at the chat now for our website where you can find our schedule and recordings. Please note that you will be muted during this presentation, but we encourage you to use the chat function to ask questions, share your insights, and speak with others attending the webinar. We'll be sure to reflect on all your comments and questions during our Q&A session at the end and unmute you all during this time. Please also note that we will be recording. We record for those who either missed or would like to rewatch the series. Please rest assured your videos will not be recorded. Only our speakers' videos and their presentations will be in the recording. Thank you all very much again for joining us. We'll now have Dr. Sandy Smith introducing our speaker for today.
Thank you, Elite. I am so delighted that I'm able to introduce to you Dr. Zeb Jamrozik. As you are aware from what you read, you know that he is a fellow in ethics and infectious diseases at Ethics in the Wellcome Center for Ethics and Humanities at the University of Oxford. What you didn't read is that he is a practicing medical physician. At the same time of being a practicing physician, he was also a policymaker as well as a critic of many of the policies regarding COVID. I am certain you will find this presentation by Zeb to be as fascinating as I expect it to be. And I am so grateful that we have somebody who does not only share of his knowledge in caring for patients, but also shares from his knowledge and his deep understanding of ethics for forming policies. Zeb?
Thanks very much, Sandy. Thanks, Alita, and thanks to the organizers for having me. I'll just load up my presentation. So today I'm going to talk about lockdown as a public health disaster. And as many of you will know, for the last few weeks, millions of people have been under house arrest in Shanghai, where this photo was taken. But it's worth remembering what well-informed, great leaders in public health thought only a decade or so ago. So Donald Henderson, a famous epidemiologist who led the eradication of smallpox, and his team wrote this paper where they said the most important principle for an infectious disease epidemic was to avoid excessive disruption of the normal functioning of the community. And by any measure, lockdown was a failure of this principle. I'm a physician and public health ethicist, so I'm going to frame this talk around some major important ethical values, talk about how we might define lockdown, what effects lockdown had on health, fairness, and freedom, and talk about what implications it might be for the next pandemic or perhaps for other disasters. The three major ethical values in public health are really health, fairness, and freedom. And public health interventions should involve responsible, ethically appropriate trade-offs between these values. And I'm using those kind of normal language terms to reflect kind of what might be more complex philosophical ideas, like health might be understood as well-being or utility. Fairness might be various ways of understanding equity or equality, and freedom might be cashed out as liberty or autonomy in various ways. And when we talk about health, some people think the World Health Organization definition of health is a bit too idealistic, but I think it's a good one. And it reflects the idea that health isn't about just avoiding one disease or about physical health. It's also about mental and social well-being. And you have to ask yourself, is that the principle that we followed with lockdowns? No, the principle of lockdowns is coercive control. Lockdown is a term from prison management, not from public health. It describes what a warden does when there's a riot in a prison, where the prisoners are locked in their cells and there are severe punishments for misbehavior. And many kind of well-known social reformers of the 19th century thought that the design of prisons, like this pandemic, panopticon prison in Illinois could be applied to other social institutions like factories and hospitals. But the COVID pandemic was the first time we tried to run a large public health response like a prison. And, lockdown as a term never featured in a pandemic response plan before 2020. The kinds of things that we had in pandemic response plans, which, can be appropriate under certain circumstances, were things like social distancing of the entire population, isolation of infectious cases, quarantine of households where there were cases, and under extreme circumstances, for the shortest time possible, things like school and university closure, which were recognized as being extremely disruptive and potentially harmful, and only to be used, for the shortest possible time. But in this same document from early 2020, the idea of complete lockdown was added, which was closure of non-essential businesses. But looking back on this document from March 2020, if this was all that was done, it might not have been too bad, because what's missing from this description is the amount of coercion and policing that was involved in many lockdowns. So I think lockdown, if we tried to give a general definition, would be a population-level public health intervention involving coercive implementation of multiple non-pharmaceutical interventions with the aim of major social disruption to reduce transmission of infectious disease. I don't think we had a definition before 2020, and I think we need to agree upon one, but this is kind of my working definition. And the most important thing here is the coercion, because without coercion, by definition, it's not lockdown. And here's an example from Melbourne, Australia, where I spent most of the pandemic. During hard lockdowns, people were not allowed to leave home except for essential reasons. They couldn't go more than 5 kilometers from home. Movement after dark was banned. Masks were mandatory outdoors. Schools and sometimes playgrounds were closed. Private gatherings, public assembly and protest were banned. Weddings were banned. Funerals were minimized. People were isolated and quarantined for 14 days each. And hundreds of thousands, if not millions of people were subject to quarantine. And the punishment for non-compliance was significant, up to fines of tens of thousands of dollars, and with significant police enforcement. And this is what life looks like under lockdown. In early 2020, people were still able to gather outside in groups of 2, as in the photograph in the top left there. But by a few months later, even 2 people meeting outdoors for reasons other than exercise was banned. Eventually, playgrounds were closed, and the police were there to make sure these rules were followed. It's important to remember that, lots of things happen in an epidemic. People do a lot of voluntary behavior change that can be motivated by altruism. They want to avoid getting infected and particularly avoid infecting others. Can be motivated by fear. They're worried about their own risk. It can be motivated by public health messaging, which can also promote altruism or promote fear or both. And as the epidemic builds and the media attention becomes febrile, people's panic leads to big changes in voluntary behavior. But in addition to this, and in addition to public health messaging asking people to do things on a voluntary basis, lockdown adds coercive policy where we force people to change their behavior and institute punishments for not doing so. And it's fair to say that that also contributes to panic. But when we look at what the supposed benefits of lockdown might be, we need to remember that a lot of the disease transmission reduction, and this has been studied empirically, is due to voluntary behavior change. And enforced behavior change only adds a small amount of additional behavior change on top in many cases, and it's not very sustainable, as I'll show you shortly. It's not sustainable because cities like New York, in this photo from the lockdown in 2020, can't be maintained empty like this. They just don't function as cities, and they weren't designed for this. So I think we have to ask, what would sustainable behavior change look like? And this has been studied. If you look at the data on mobility trends, these are UK data below. If you look at the first extreme lockdown in early 2020, there were significant reductions in mobility around the country, around cities, down reductions of up to sort of 75%, but that wasn't sustainable. And a pandemic is a long game. So if you look at the long game, what we can sustain is maybe a modest, 25 or 30% reduction in workplace visits, transport and retail contacts. And what can be really positive is encouraging citizens to use outdoor space where the risk of transmission of most pandemic viruses is extremely low. And you can see the increase in use of parks in the UK, especially in summer, was probably a positive effect of public health messaging, and didn't necessarily require coercion. In fact, coercion of outdoor behaviour might actually make that positive behaviour worse. But here's an example of what happened with non-sustainable change. In Australia in 2020, Melbourne, Victoria had already been through many months of lockdown. And the mantra at the time was that hard and fast lockdown was the way to go. And in 2021, there was an outbreak in both Victoria, Melbourne, and Sydney, New South Wales. And in Melbourne, we had hard and fast lockdown, going to strict rules on day one, the moment the first couple of cases were notified. Whereas Sydney adopted a more moderate approach. By the first week, they'd put in indoor density limits and stay-at-home orders in high transmission areas. At the end of the first week, there were stay-at-home orders for the whole city, but people were still able to go to retail premises. Then there were limitations on outdoor meeting and behaviour. Then at day 34, true kind of lockdown, closure of non-essential businesses, and eventual increase in police enforcement and fines. And at this point, many people said, you see, Sydney, things are going worse for you. You should have done a hard and fast lockdown like Melbourne. Things are getting out of control. But actually, again, it's a long game. And over time, actually, the Melbourne transmission exceeded that of Sydney, adjusted for population. And one recognized reason for this is so-called compliance fatigue, that people just could not keep complying with strict rules for so long, especially when they're exhausted by having done so for months in 2020. So we need to think about what's sustainable. And importantly, there are things lockdowns can't do. Lockdowns cannot protect essential workers who are going to have to continue going to work. They can't work from home on their laptops. Lockdowns can't protect people in nursing homes because essential workers have to work there. And it's in many cases, epidemics occurred in nursing homes despite lockdowns. And lockdowns cannot prevent infections and cannot make people immune. Hong Kong depended on lockdowns of various kinds, failed to vaccinate its elderly population. And when the Omicron variant took off in Hong Kong, they had an enormous case rate and enormous case fatality rate, one of the highest in the world, with about 1 in 20 people diagnosed dying, and many of those older adults who could well have been vaccinated in the time that they had. But unfortunately, over-reliance on non-pharmaceutical interventions, among other things, led to a low vaccination rate. So now I'm going to talk in more detail about the potential collateral harms in terms of health arising from lockdown. It's clear in retrospect, and in my view, it was clear in mid-2020 that outdoor interventions are a net harm. We are more than 2 years into the COVID-19 pandemic, and there has not been a single verified case of outdoor transmission where it's been shown that one individual infected another individual when they only met outdoors and where the genetic strains of the pathogens match. Now, there may well have been rare cases of outdoor transmission that we didn't identify, but the fact that we haven't even found one suggests that it's exceedingly rare. And it just seems cruel to be doing things like closing playgrounds and preventing people from meeting outdoors under those circumstances. And we lost major lessons from the history of public health. 100 years ago, in the tuberculosis pandemic, it was recognized that outdoor play is as necessary to health as food or sleep. And in particular, it's necessary to avoid catching respiratory infections, which are much more likely to be transmitted indoors. Another thing that was clearly a major net harm was prolonged school closures. Pandemic plans were clear that school closures should be for the shortest possible time and only in extreme emergencies. And that was because there were enormous harms to children and young families and parents. And, there's been massive learning loss across the world. There's countless children who never come back to school, including an estimated around 10 million additional child marriages worldwide. And we have to ask ourselves, how much did this really contribute to the suppression of transmission of COVID-19? How much did it contribute to the reduction in burden of that disease? I think, not as much as people hoped, and the harms are clear. Likewise, there's been a massive increase in mental health deterioration, particularly among young people due to lockdowns worldwide. There's been a huge increase in alcohol use, culminating in record deaths due to alcohol in the United States, among other places. Obesity is on the rise due to closure of gyms and people being kept in their houses. And this will be a pressure on population health and health systems for years to come. And even there's been some unexpected harmful, terrible harmful consequences. Like in Australia, we had a significant increase in child drownings. Why? Well, because swimming lessons were banned. There were several tragic cases of parents who were struggling to work from home and supervise their children at the same time, and the children stumbled into a body of water and died. These are avoidable. These are children who in some cases had 80 years to live. And this is not a death caused by a virus. And many of these harms are caused by our policies, not by the virus itself. Likewise, if we suppress the transmission of all kinds of infections across the population as a result of stringent public health measures, well, eventually nature is going to come back with a vengeance. Here's another virus, respiratory syncytial virus, which is dangerous, especially to young children. These are data from New Zealand. And in the green data on the bottom there, you can see that New Zealand totally suppressed RSV in 2020. But as soon as New Zealand opened its borders only to Australia, in the red line there in 2021, there was a massive epidemic of RSV. And we've witnessed this all around the world with all kinds of pathogens that when they come back, they come back to an increased degree. And that's because there's less population immunity across the population as a result of suppressing these endemic infections for up to 2 years. So this is an avoidable harm of going too far with stringent public health measures. And all this is not to say that COVID-19 wasn't a formidable challenge. I'm a hospital doctor. I have immense sympathy for the people who fell ill and died and for their families affected by COVID, and also for the healthcare workers placed under immense strain. So much so that people brought out these kinds of quotes like Winston Churchill from World War II, originally used for airmen soldiers, that it was a situation where never had so much been owed by so many in the population to so few. And people start to think about healthcare workers in this way. But if you actually look at the population level and lockdown, there's another kind of difference here. One is that even though huge numbers of people were harmed by COVID-19 in the early waves when there was no immunity, about 50,000 people in the United Kingdom, for example, this constituted less than a fraction of 1% of the population who died in wave one. And if you were aged under 40, which is the median age in the United Kingdom, your chance of going to ICU with COVID in that wave was less than 1 in 36,000. And if you're healthy, it was much less than that. And yet you were being asked to participate in stringent punitive public health measures. And the potential population size that could be harmed by these measures was up to 67 million people for 3 months. So we have to think about the trade-off between benefits and harms here, and we have to acknowledge that it's significant. In Melbourne, for example, which at one point was the place, at least in a democratic country, that had been locked down for the longest in the world, we had 5 million people locked down for 9 months. And in epidemiology, we have ways of thinking about interventions that last for large numbers of people for long periods of time, which is the idea of person years. So this was the equivalent of locking up 3.6 million people for 1 year, or one person for 3.6 million years, if you like. And insofar as that in itself causes harm, that can be a significant amount of harm. If you think that lockdown of the type I described reduces quality of life by, say, 1%, then quality adjusted life years, which is a way of thinking about how we kind of weigh harms in this context, that adds up to a significant amount of quality adjusted life years, maybe 36,000. So that's like 36,000 years of human life of high quality were lost if the reduction in quality of life due to lockdown on average was around 1%. Of course, if it was 5% or 10%, then it's a much bigger health harm related directly to lockdown. And we have to weigh this against the potential benefits. A reasonable estimate of how many COVID deaths were averted in Melbourne in the first early part of the pandemic was maybe around 8,000. That's a kind of generous estimate. That's a large number of deaths averted. But most of those deaths were in older adults or people with severe comorbidities. And on average, each of those people had sort of 5 to 10 years to live, often with reduced quality of life. And a reasonable estimate might be that that was around 32,000 quality of life years that we saved as a result of avoiding or at least delaying COVID deaths. And if you think about just the harms of lockdown itself, if the quality of life loss is around 1%, then that already exceeds in some ways the COVID deaths. And you have to ask yourself, what's going on here? And what's clearly going on here is that people are giving additional moral weight to COVID deaths as opposed to other kinds of health harms. Because this is just the direct effects of lockdown, just the psychological burden of being locked in your house and so on. And to that, we have to add mental health harms, alcohol, obesity, and so on, as I mentioned before. And it's pretty hard to argue that we could have been confident in early 2020 that the benefits of lockdown would have outweighed these potential harms. So in summary, from the point of view of health, many elements of lockdown produce net harm, especially outdoor interventions and school closures. It's unclear that the benefits of coercive policies outweighed the harms. And I think for the next pandemic, we should be aiming for sustainable voluntary behavior change and reserving kind of stringent extreme measures only for very short durations at the peak of epidemics, rather than making them long duration when people can't possibly comply for that long. Now I'm going to talk about fairness. Again, in Melbourne, Australia, 2 years ago, suddenly the 3,000 people living in these public housing towers found themselves under house arrest with no notice, with no time to gather supplies. Police surrounded the buildings. People were locked in their apartments and systematically tested for COVID as a result of an epidemic in one of the buildings. And this wasn't the only place epidemics were taking place, but it was the only place that people were treated with such draconian measures. And this is an example of, one way in which, the response in lockdowns was unfair. We demanded or even forced people to participate in restrictive policies, but we didn't give them the resources they needed to participate. And it's clear that we need to provide resources before we force people or even, recommend that they restrict their behavior, because it's just not fair to ask people with less resources to participate in such stringent interventions. A second way in which lockdown is unfair is that insofar as there's benefits of lockdown, well, those benefits occur mostly among rich people who live in large, uncrowded houses and who can work from home. So in Toronto, in this example, in the richest, most white ethnicity suburbs, when lockdown's instituted, the amount of cases goes down. But if you live in the poorest and most non-white ethnicity suburbs, well, then lockdown doesn't really do a great deal for you. It does much more for the rich. And the third way in which lockdown policies were unfair is that the punitive measures, the over-policing, was often targeted at people doing low-risk behaviours, who were low risk of COVID, and who had the most to lose from these interventions. So in New South Wales, for example, where Sydney's the capital, $50 million worth of fines were handed out to people for what were really mostly minor infractions. And $2 million of those fines were for children. Now, I just can't imagine that it would be justifiable to fine children, say, $5,000 for meeting outdoors during a respiratory virus pandemic. And I think we'll look back on that as a mistake. But the fourth most important way in which lockdowns were unfair was their global effects. Countries like South Africa, Uganda followed other countries into lockdown, and this forced huge numbers of people into food insecurity and needing to line up for essential supplies. And that led to Alex Broadbent, a rare academic, wise and brave enough to critique lockdowns from the start, who pointed out, rightly, I think, in early 2020, that lockdown was not the right intervention for Africa, where, in sub-Saharan Africa, the median age is 18 years old. And this was just never going to be the same kind of public health priority as it might be for a country like England, where the median age is 40. And just this week, Oxfam has looked at global inequality and found that by every dimension, inequality has skyrocketed since the start of the pandemic. Billionaires have tripled their share of global wealth, and many poor people have become poorer. And, some of this, could have been due to a virus, but most of this is due to the policies that we've adopted in response to the virus. And this is going to have health harms at the global level for decades to come. So in summary, the benefits of lockdowns were greatest for the old and rich. The harms were often greatest for the young and poor. And I think one of the goals we need to adopt for the next pandemic is to provide resources to people before we ask them to participate in restrictive measures. And lastly, I want to talk about how lockdown is a disaster for freedom. I mean, by definition, if we're instituting coercive policies, that means we are restricting freedoms. And, bioethicists, public health ethicists have worked on conditions under which we could institute, severe restrictions of liberty or autonomy. And it's just unfortunately the case that in many cases, those conditions weren't met when stringent draconian measures were put in place during COVID-19. And there's all sorts of freedoms at stake here. There's freedom of movement, freedom of public assembly, freedom of protest, freedom of expression, freedom of bodily integrity, free choice of occupation. All of these freedoms were severely limited. And as the great American artist Jenny Holzer reminds us, abuse of power comes as no surprise. When you allow a small number of public health officials to institute just any measure they can think of and not have to justify it appropriately, it's inevitable that we're going to see abuses of power. If you allow police to behave punitively and fine people for minor infractions, that's going to get overused, unfortunately. And looking back, we have to ask ourselves, did we really need so much liberty restriction as we had? Did we really need to ban outdoor protest? Did we really need to force people to wear masks outdoors? Did we really need to ban hospital visitors so that people were sick in hospital and in many cases died alone? Did we need to ban visitors to maternity wards so that women gave birth alone, so that families couldn't welcome new babies into their family? Did we need to ban people from meeting up outdoors with their friends and family, even though the transmission of respiratory viruses outdoors is extremely low risk? Did we need to make people live in fear, surrounded by riot police? I don't think we did. And it's worth remembering that people got addicted to these restrictive measures. When the United Kingdom announced in mid-2021, with basically the entire population vaccinated after an excellent vaccination campaign, that they were going to drop all coronavirus-related public health rules in the middle of summer. Many people said that it would be a complete disaster, that we needed those restrictions to keep the virus under control. The modelers came out and produced models like this model in red, suggesting that there would be a huge epidemic immediately as soon as restrictions were relaxed. But the black line at the bottom shows that that never occurred. And what it shows you is that it was not the restrictive, coercive measures that was keeping the virus at bay, that was keeping hospitalizations at bay. It was voluntary reductions in human contact where it could be high risk. And it was vaccination, which is arguably the most important intervention to reduce hospitalizations. And we have to remember that so many of our policies were driven by these kinds of projections that massively overestimated the hospital strain that was going to result from COVID and led us down this path to extremely coercive interventions that in retrospect, in many cases, look ethically unjustified. So in summary, from the point of view of freedom, it's clear that freedom to engage in low-risk activities like meeting other people outdoors should be encouraged. It's great for physical health, it's great for mental health, it's great for the normal functioning of society. And over-policing is bad for public health. Most people in public health in democratic countries agreed on this before the COVID-19 pandemic. So I was surprised to see so many people in public health rallying for punitive policies that in retrospect don't look so good now. And so I think for the next pandemic, we want to aim for no punitive public health policies. We want to try and engage as many people to participate voluntarily, and we want to avoid situations where there's an increase in social discord because of overly coercive interventions. And with that, I just want to remind everyone that coercive mass population interventions have unintended harmful consequences, not only for health, even if they can produce some health benefits, but also severe consequences for increasing unfairness in our society and for excessive restriction of freedom. And when lockdowns were brought in, many politicians said, we have no alternative, we have to follow the advice and so on. But there's always an alternative. In fact, there's thousands of alternatives because each kind of public health response is made up of lots of different policies, and we can choose the ones that are the most likely to produce benefits without involving these significant harmful consequences. And we can eschew those that involve excessively bad outcomes for the worst off, excessive coercion, and excessive harms to health. And with that, I think we should aim for, as I said, voluntary and sustainable interventions next time. We should aim to provide resources to people who are subject to restrictions, and we should aim not to overly police those restrictions. A small amount of non-compliance can actually be tolerated without causing things to go out of control, in part because many people are altruistic enough to do significant voluntary measures to reduce the risk of transmission of pandemic infections. Thanks very much, and I look forward to questions and comments.
Thanks a lot, Zeb, for this really thought-provoking presentation. I think I have a lot of questions, but of course, I mean, if you have questions, you can either ask them like orally, or you can post them in the chat, and then I'll read them up. So I'll give the floor to some of the participants, but if there's none like now, I have some burning questions that I would like to get off my chest, but I'll give people, but maybe I can ask sort of the first one before we. So the obvious one, Zeb, would be, do you know why? Why did we engage in this sort of lockdown? I mean, you mentioned that a lot of the health experts were actually sort of part of this. It wasn't, you can't sort of just blame politicians for overly precautionary measures and thinking about elections and so on. So why did we deviate for the plans? I also noticed some of the policy recommendations. I guess they were sort of the normal response you would have before COVID as well. So the policy recommendations you had at the last slide would be, normal policy recommendations before COVID that most health agencies would follow. I know in Scandinavia, these lockdowns measures were reserved for much more contagious diseases and much more lethal outbreaks than COVID. So why is it that across the board, and to varying degree, of course, I know Melbourne was extreme, that we applied these what was it that changed? Was it, why did we do that? Do you have some, because I'm a little bit puzzled myself.
Yeah, I mean, that's a big question. I think we're going to be unraveling the answer to that question for kind of decades to come. But if you look at what happened early in the pandemic, I think two kind of things jump out at me. One is the overuse of fear. So governments really cranked up people's fear about this disease way out of proportion to what we knew about it from the data coming out of China. Exaggerated the risks to young, healthy adults and children and so on. I think that was a mistake. And what social scientists that were advising various governments did say there could be negative consequences for using too much fear. And another kind of negative consequence, as a negative framing of policy, as I kind of alluded to, was this moralization that more moral weight was given to COVID deaths than to anything else. And people were unable to see that there kind of were trade-offs and that people were willing to make incredible sacrifices to avoid COVID deaths. And I think it would have been better to have kind of more informed debate about the fact that this is one health problem among many, admittedly extremely pressing, extremely challenging and so on. But that we had to acknowledge that dealing with it, if we went too far, might lead to other kind of knock-on health effects. And I guess another thing was certainly in places like Australia, but also in other places where it became seen as a kind of outside threat that could be prevented from coming in, whether that's kind of prevented from coming into your household or into your community or into your country and so on. People became very focused on preventing that and were willing to even use the military to try and prevent a virus, which isn't known to be a great kind of strategy. It's hard to say why there was so much enthusiasm for this, but those would be kind of three factors I think that were at play in early 2020.
Yeah, well, just a quick follow-up, and then I'll have the question. So I think I agree, but what still puzzles me a little bit, because some of these mechanisms would be obvious, for politicians and so on, but why did public health experts who pride themselves on sort of balancing and evidence-based decision-making and so on, and it's not like the initial 2 weeks of precautionary where we didn't know, a lot of uncertainty, we didn't really know what we were dealing with, and then you go to a lockdown, but it was the sustained lockdown for a long time. I'm just surprised that also a lot of sort of public health experts bought into that, and I know from Scandinavia again, sort of the inquiries that were made on a national level, it's not like there's this huge sort of wave of self-reflection and saying, well, this might be wrong. I know even when they say the policy might be wrong, they say it had immense symbolic effect. That's usually what they say. It might not have, like the lockdown of schools, for instance, might not have a huge effect on transmission, but it had a symbolic effect because it sort of made a point to the public about how dangerous this disease was and so on. So that's how they justify some of these, I know, in the national sort of assessments and so on. But let's move to some of the questions I can see in the chat. So Alexandra asks, first of all, wonderful presentation. Wish I had it in medical school. So that's a good. So, and then the question is, what are the top recommendations for incoming residents entering medicine during a time of inconsistent evidence-based medicine, lack of open discussions and debate, and intense societal pressures to conform with critical thinking? And this is from a person in the US.
Yeah, I mean, I think it's incredibly difficult. I mean, one thing is to always maintain a critical mindset when it comes to evidence, and to ask, well, what's the evidence that this works, or what do we know about the benefits and harms and so on, and to be always to keep asking those questions. But I know from my own experience that there was a lot of pressure not to ask questions and not to apply the normal standards of kind of evidence-based public health or public health ethics. I think the United States is probably one of the worst places in the world in terms of polarization. At least that's my impression from the outside. And so my only advice to you is really to try and find like-minded people to collaborate with, and just also give people time. I think people have been panicking nonstop for the last 2 years, and I'm hopeful that as more people come down from the kind of fear and panic related to COVID, we might be able to have more rational discussions about, how to apply standards of evidence in public health, and how to apply standards of ethics to public health interventions, and what went wrong here. I'm hopeful of that, but we have to wait and see.
Thanks. And then Dave is asking, some measures such as mask wearing and distancing are much less draconian than lockdowns. Would it make sense to push those measures more strongly as compared to stricter ones?
Yeah, I think so. I think that if I had to pick one intervention that was part of lockdown, it would be reducing large indoor gatherings, because it was clear that so-called super spreading events in poorly ventilated, overcrowded indoor spaces were and continue to be the main driver of the pandemic. And that's probably the one I would have chosen. I think that would probably be more effective than masks. That might be controversial, but that's kind of one part of social distancing. And I think we should have pushed that a lot harder in this, well, not a lot harder, but in the sense of, being clear to people that these are the high risk environments, that we really want you to avoid those environments. And for short periods of time, mass closures of businesses, or strongly recommended closures, for example, could have a very large effect without necessarily the need to kind of punish people for non-compliance. And I do think that, a lot of such measures and, careful public health messaging, and also attending to workplaces, a lot of the transmission of COVID was occurring in essential workplaces, occurring in nursing homes, occurring in meat packing plants and so on. We might have been better to focus our efforts where we could get the most benefit, rather than focusing it on kind of low risk, young, healthy adults meeting outdoors. I think that part is pretty clear now, and was clear in 2020, in my view.
Okay, so I have another question, maybe sort of so I'm not an ethicist, so I don't know a lot about philosophical theories and so on, but it seems to me in the extreme that what you did at some point was to a very sort of utilitarian perspective, where you compared like the loss of life quality with the loss of lives and all that, and you said, like, because they only had 5 to 10, but are there not sort of other ethical or sort of ways of looking at it? I'm thinking, like, let's say that COVID-19 only hit the gender, the like light skinned or the dark skinned, or people, or only males, or only females. That there's also this like a life, I guess, is a life, even though it's, you know, all, I understand what you're saying, but there is also this like that sometimes you can't apply utilitarian principles, but you have to protect the ones that the diseases. Do you get where I'm going with this?
Yeah, I mean, I think there's a couple of issues there. I mean, the first issue is that look, everyone agrees that it's worse to die young than to die old. You know, that's a thing that everyone can agree on. But then we need to work out how to prioritize those things. But there's no choice that's value free. So once you decide you're going to prevent COVID deaths, and those COVID deaths mostly occur among older adults and people with comorbidities, you're by definition prioritizing the interests of those people over other people. And we just have to be aware of that means other people are being deprioritized. But your kind of second point about fairness and justice, yeah, it's a standard idea in public health ethics that if a disease is disproportionately affecting worse off people in society, then we should do more, relatively speaking, to protect them. And we did see that in COVID, obviously. You know, there were significant increased harms among many marginalized groups across multiple societies. And you can think of, for example, nursing home residents as a, you know, potentially more vulnerable group in that way, to whom we should provide greater resources, even if they only have 1 or 2 years of life to live. You know, so I think that's true that you know, we should provide additional resources. But I guess two things. You know, one is that it would have cost a lot less to focus resources on nursing homes than to shut down society for months at a time. And second of all, you know, the well-being of nursing home residents, again, isn't just about avoiding a virus. Yeah, this virus in nursing homes, it does have a very high fatality, around 25%. But, you know, people in nursing homes who have only 1 or 2 years to live, they also need to see their families. They need to be able to have kind of some social interaction. They need to be able to communicate insofar as they can. And so I don't think it's just about kind of reducing harms from the virus. It's about striking reasonable trade-offs.
Yeah, well, that's a good answer. So I do apologize. I can only see Zeb and myself on the screen. So I understand that Prue has a question.
Yeah, hi. Thanks, Zeb, for your talk. This is more, I guess, an observation that I find interesting, and that's that I think, you know, it's fairly common now that health services make a big point, and it's a good point that we should, you know, really involve our patients in what we decide and how we provide healthcare. You know, involve consumers, put patients first, listen to what patients want. So, and what I find interesting is how we've really gone against that in some of the decisions we've made, particularly on the behalf of what so-called vulnerable people. Now, we've actually never, I don't think, generally, I guess, investigated what vulnerable people will want in this, you know, and I guess I think if the problem is that if you asked a lot of people now, you know, if they thought everything was justified, they'd probably say yes. But if they, I guess, were presented with more balanced facts around, you know, COVID, and the fact that, you know, for young people, it's not particularly risky, and for older people, yes, it might, you know, reduce your life. But, you know, the flip side of that is that you can avoid it, and would do everything to avoid it. But in that path, you know, not see your family, not hug your grandkids, not do things that are important to you. And so we've never really asked people if what we've done with, you know, all these things that we've said are protecting you, of actually they think have protected them, which I find quite sad. You know, I think, and I think it's probably highlighted by a talk I heard by a geriatrician who works at our hospital, who said that, you know, a lot of, and this geriatrician works for a service that tries to, I guess, stop nursing home residents from being admitted. And she said a lot of the nursing home residents she saw, she said, you ask any one of them who, you know, if they prefer to hug their grandkids or, you know, be stuck in isolation, and they all prefer to hug their grandkids. And we heard those, I think, and that's.
Thanks. I think the audio might have dropped off there, but I heard the part up to hug their grandkids, and I totally agree. And again, it's not just nursing home residents, it's kind of everyone in society has multiple values in their life, and one of those values is avoiding getting sick, and the other of those values is interacting with other people. And yeah, well, I mean, what I think is kind of tragic is that there were ways to facilitate this kind of thing, especially taking advantage of outdoor space, for example, encouraging people who live in the community to meet outdoors rather than indoors, and even nursing home residents, taking them outdoors to meet their families and so on, rather than locking down the nursing home. And yeah, I agree. I don't think we often talked about protecting vulnerable people without acknowledging that there's a huge diversity, even within a particular group of vulnerable people. Some of those people really want to prioritize not getting infected. Some of those people are willing to take some infectious risk in order to have more social interaction. And when we apply a blanket rule, we kind of paper over that variation in kind of human values, and that in itself, it can be a problem.
So we have a question for Dave. From Dave.
Okay, thanks.
Yeah.
So I'm going to just present a personal experience, which is pushing back a little bit against what you're saying. And I do take your point around draconian measures and how it can be an overreaction, and we need to take an evidence-based approach. My confidence in people on a voluntary basis behaving well is limited. So a few weeks ago, I was headed downtown with a family member who's immunocompromised, and because of a flat tire, we ended up on the subway to go to a doctor's appointment. And there's a rule in the subway in Toronto, you're supposed to be wearing a mask. So even when the province or city lifted the restriction, the Transit Commission was still keeping this rule in place. And at one stop, a whole group of young kids came on, basically surrounding us, none of them wearing masks. And I was both angry and morally outraged. And I was morally outraged because our right not to be infected is more significant than their right not to wear a mask. And so the argument, so a blanket argument against mandatory measures does not resonate with me because there are times when I think mandatory measures are called for. And I'm not talking about lockdowns, for example, which can be extreme and draconian, but certainly relatively mild things like mask wearing, which especially in a closed little area like a subway where you're surrounded by people who are not far from you at all just because there are so many. It seems to be such a small thing to ask of somebody to put a mask on in those sorts of situations. But if you ask on a voluntary basis, many people just do not do it, And yet we ask people to give up all sorts of freedoms in society. They have to wear seatbelts, they can't speed. I mean, just because of our social construct, we impose all kinds of restraints, reasonable restraints on people for, well, even their own good, but also the good of society in general. And I don't see why that approach should not have some inroads into public health measures as well. And that's not saying that we did not go overboard in places, perhaps in terms of mandating public health measures, but I'd be very uncomfortable with the notion that all measures should be voluntary. So I wonder how you respond to that.
So I'm sympathetic to the plight of people at high risk of various things, although it's worth mentioning that immunocompromised people, they were at high risk of lots of pathogens before the pandemic. They'll be at high risk of lots of pathogens after the pandemic, and we shouldn't just focus on one pathogen. The other thing worth noting is that the real world effectiveness of masks might not be as high as many people think. So I know it's intuitive to feel moral outrage, but we also have to attend to the actual risk difference, being made by one particular, asymptomatic individual wearing a mask or not. And it might not be as high as people think, but you want to see people, taking altruistic actions of various kinds. And I hear what you're saying, that, we can't necessarily rely on everyone to be altruistic and to voluntarily comply with reasonable public health measures. My own view is that we can probably accept more non-compliance than people think, and also that there was more compliance than a lot of people think, because people tend to focus mentally on the non-compliance and not on the fact that many people were doing things voluntarily all the time. But I guess one important point I think is there's mandatory measures as a group, and there's severely punitive mandatory measures, and that you can institute a fine. You can say, if you don't wear a mask, you can be removed from public transport at no cost to you, but you'll be removed. Or you can say, if you don't wear a mask, there's a $5 fine, or you can say there's a $200 fine, or you can say there's a $5,000 fine, and we can drag you away to prison, or at least lock you up and take you to the police station. And so I think I'm willing to countenance something, down the kind of less stringent end of mandatoriness. But the policies that really bother me are the ones that allow kind of hard enforcement of relatively minor infractions. And I think, forcibly taking people away and putting masks on them is maybe going too far.
Okay, so what do you think the prospects are that the next pandemic will be dealt with differently? Because as I alluded to before, I think a lot of the sort of national assessment and inquiries are, somewhat critical at some points, but I don't see, that there is still this tunnel vision, or what you would say, I guess, is a tunnel vision, that we prevented this and this amount of deaths, and we only had this and this amount of COVID-related deaths, and that other health concerns are secondary if they are at all talked about in the report. So what are is it something you think will happen automatically during the next sort of 2 to 5 years, that there'll be a more nuanced picture of what we did, and other sort of effects will emerge, or so how do you see, or do you think you need to do sort of a concerted effort, and a lot of academics need to pressure, and it needs to come from within the health agencies themselves, or how do you see the prospects of learning the way you want us to learn?
Yeah, well, I guess on the pessimistic side, it's going to be hard for a lot of public health leaders to admit that the severity of some of these mistakes. On the optimistic side, if you look after the 2009 influenza pandemic, at the time there was a lot of panic, billions of dollars spent on antivirals and so on. And only a few years later, people looked back on it and they said, gosh, that was an overreaction to that pandemic. Now, that pandemic was nowhere near as severe as the COVID-19 pandemic. But I think we will still be able to look back on COVID-19 and say, some measures were justified, some measures were an overreaction. So I'm hopeful that at least some of that can happen, but I am worried about the precedent being set for lockdowns, over-policing, punitive measures, because it's a real break with the tradition in public health where they always said the police is the last resort. We want to engage with populations. We don't want the police too intimately involved in public health intervention and so on. It's a real break with that tradition. And so I think there we really need a lot of general community effort, and among academics, a lot of academic effort to determine the conditions under which you might want to do this again or not, as the case may be. And things like school closures. I mean, I think history is going to judge prolonged school closures for COVID-19 very poorly, and that's something that society really needs to come to terms with, and maybe as almost a number one priority. And then these issues about over policing.
Yeah, that's true. There's a question. Oh, sorry. There's a question again from Alexandra. What are your thoughts on masks being a false sense of security? Most of the general public were wearing a mask, still wear cloth masks and surgical masks.
Yeah.
And I guess it's also like, it's not so much yourself. It's the effect is the other way around, that other people should wear masks for. So you're not as protected when you're just wearing a mask yourself, right?
Well, yeah, I mean, unfortunately, we just don't have great data on this because they haven't been studied in the right way. And most studies of masks in the community have been negative, and the most adequately controlled studies. Cloth masks not only don't work, they've been shown not to work in a randomized controlled trial or two. And I do think, cloth masks, it's hard to argue that they produced a major change in risk. And, we need to always distinguish between what a study of, say, a surgical mask shows in ideal settings where it's worn for a short period of time by a trained professional, and what the actual efficacy or effectiveness is like in real life, where someone's wearing the same surgical mask for 10 days in a row, checking it in and out of their pocket. And, I think the focus on masks in some ways has been unhelpful. There's clearly high risk settings where high quality masks can make a difference. But the over focus on masks, I think, has taken away from other, in my view, far more important things like, large indoor gatherings, encouraging people to meet outdoors and so on. I don't think masking outdoors has made any difference whatsoever, for example. But I think we should focus on the things that are likely to produce the most benefit, and focusing on masks has been divisive and hasn't always produced as much benefit as people hoped, I think.
Yeah. So the last question from Sandy, do you have a sense of the percentages of countries that utilize punitive lockdowns?
I don't have a sense off the top of my head, but if you look at there's the so-called, what is it, Global Stringency Index on the, is it the Oxford Our World in Data website that has tracked the stringency of public health responses across multiple countries worldwide. In short, a lot of countries, I think the real tragedy is that, once high-income democracies adopted lockdown, then there were many low-income countries that followed high-income countries into lockdown. And as I pointed out, if you just look at the population structure in most countries in sub-Saharan Africa, the other health challenges they face, the immense amount of economic and food insecurity, you would think maybe lockdown isn't the right thing to do. And children in Uganda were out of school, if they're not still, for kind of 2 years. These are kind of disastrous effects on, some of the more vulnerable members of our planet. So I think that's probably one of the worst outcomes of the spread of this kind of policy worldwide.
So I said it was the last question. Just one more from Michelle, and then we have to end. Missing periods of classes were so damaging that they are considering bringing back grade 13. What should have been the approach in your opinion? I guess it's on school closures.
Yeah. So I think school closures were in pandemic plans, and they were only for extremely severe pandemics, like 1918 flu, and or only for the very peak of an epidemic. We could close for short periods of time when health systems were really, really overwhelmed, and then schools had to open as soon as possible because the effects on children, the effects on parents, especially young women, were recognized to be disastrous. And so I think we should have just followed the pandemic plans. The school closures are a last resort. They need to be only at the peak of transmission and for the shortest possible time. And then I think it would have been okay. But these prolonged school closures, it was obvious they were going to be a disaster, and they should never happen again, in my view.
Okay.
Thank you
Michelle
again.
says thank you. Yeah, thank you so much for this really nice presentation and also the Q&A. And I think a lot of people will watch it. I know in Europe at least would watch it on YouTube. So Sandy, do you want to introduce the last speaker or say something?
I look forward to facilitating a discussion next week, next Wednesday, June 1st. It will be at 9 a.m. Central Time, 10 a.m. Eastern Time. This is, of course, on North American time. And look forward to you joining us as we consider what's doing the right thing. And Zeb, you are absolutely doing the right thing. And I really appreciate the fact that through all this COVID, that you were thinking about policies and you were helping to critique, not only critique, but helping to write them, as well as caring for patients. Thank you so much for your gift of service.
Thanks very much, Sandy.
Thanks so much, Seth. Bye, everybody.